few years now, and he was a little bit modest. He forgot to mention in his bio that he's also this chapter's HIE liaison. He's on the board for New England Hymns as well. And introducing our next speaker is Christina Salvini from CDW, and she's going to introduce our next speaker. Thank you.
Good afternoon, everybody. My name is Christina Salvini. I'm with CDW Healthcare. We're a sponsor of the regional chapter here. I want to thank everyone for coming out today. Hopefully you're enjoying yourself on this Friday. I do have the great pleasure of introducing Mr. Manu Tandon. Manu is the Secretariat Chief Information Officer for the Massachusetts Executive Office of Health and Human Services, also responsible for Massachusetts HiWay. I did a little bit of light stalking on LinkedIn to get a little more information about him. And I think a nice little fun fact is that this year, in February actually, Computer World named him one of the 100 premier IT leaders in the world. So I think that's a great achievement and deserves. Mr. Manu Tandon, thank you.
Good afternoon, everyone. Pleasure to be here. I'd like to talk to you about, okay, let me just figure this out first. I know I'm not Health Infonet. I know that. I'm going to close that out. Hop over to my, okay. Got it. Okay, so good. I'm all tutored up now. Great afternoon to be inside, isn't it? Will we ever get summer? Pleasure to be here, as I said earlier. What my role in Massachusetts is, for those of you who may or may not know how government works, Massachusetts is basically divided up into 8 secretariats. Health and Human Services is one of them, happens to be the largest one of them. It's made up of 15 agencies, very wide range of services, but essentially, as the name suggests, everything to do with health and human services. So, honored to be here, great to hear the presentations as well as share with you what's going on in Massachusetts. So, in a broad way, essentially what's going on in Massachusetts, what's going on in every other state, which is Affordable Care Act. Affordable Care Act, if regardless of what political affiliation one may have or what views one may have about its pros and cons, there's one undisputable fact about ACA, which is that it was great for IT. It gave us funding like never before to do things like never before, and I'm not sure how far it's true, but I read a study somewhere else where it said that the healthcare industry is actually second only to the mining industry in its lack of use of technology for administrative purposes. This from an industry which obviously, does amazing things when it comes to clinical technology, because obviously, as we all know, US is one of the leading nations when it comes to rendering healthcare. But when we talk about use of technology for administrative purposes, I think we have a long way to go. And as I'm sure you all know, it's actually not about the technology. It's, the fact it is what it is because of programmatic reasons, systematic reasons. Previous speaker talked about the fee-for-service models and how we reimburse folks and how we motivate folks and privacy and security. It's a multi-dimensional problem set which requires a multi-dimensional solution set. That's just how as simple as I can put it. And very, if you like Rubik's cubes, if you like to solve difficult problems, this is the space to be in. It is phenomenally complex. You're talking about humans, you're not talking about widgets. It deals with consent and privacy and accuracy. And do I do what Maine did, bring data in, or do I leave data where it is? There are pros and cons both ways. Massachusetts, we had a healthy debate about this, and I think we ended up in the spectrum, and I will go through some slides about this as well. Is basically we ended up on the policy side of this, where we said that we don't want to create a longitudinal record at the state level. There's several reasons for that, but essentially where we ended up was that we thought that the health records should sit where they are. They should sit in the hospitals, with the payers, with the provider organizations, with the health community centers, what have you. What we do want to do, though, is we want to know where the data is. So our approach is something called sort of a relationship listing services. So if you think of a relationship as, that exists between, say, me as a patient and a hospital, and that could exist between me and the patient as the same patient in several other hospitals. I may have, over the course of my lifetime, built several relationships. If I could centrally list those relationships for me, then if I am in an emergency situation in out of state or where, what have you, right, nobody knows where my health records is, they could go to a central place and look up where my relationships are, which would then, enable us to pull the data down. So that's the model that we have settled on. We have had a long history around HIE in Massachusetts. NEHN, for those of you who are aware of, New England Health Electronic Networks, has existed for years. It already had, I think, upwards of 55 hospitals, from about 70 hospitals that we had in the state. So there was a lot of experience in it, but the fact was that not everybody was getting connected, and there was a barrier of entry to NEHN or to similar HIAs, which was generally cost. It ended up becoming the network of the haves and not the have-nots. So from a state policy perspective, you have to think through it from that perspective. You can't have Eastern Mass have something that the Western Mass doesn't. And then you also want to go down, up and down the longitudinal scale too, right? You don't want to just have hospitals. You also want to have individual physicians groups that would participate in this. And then as someone asked a question in the previous speaker, it's not just about the clinical health, it's also about behavioral health. It's not just about physical health, but about the mental health as well. So happy to launch into a few slides that I brought along. The slides are just here to enable some discussion. We have a lot of time for this session. I'm not sure I'm going to be able to talk that long, but we can have some questions in the end. So that's the general plan, okay? You ready? So Massachusetts has been a leader, as you know, in healthcare innovations. I'm sure a lot of states can't say that, but we do have some history. We were the first in the nation to, back in 2007, to pass Chapter 58, which was known at the time as Care, which essentially focused on universal health coverage. And then in Chapter 224, which was passed by Governor Patrick recently, was the first in the nation to lay out a cost containment plan, where essentially the growth of the healthcare segment was pegged to the growth of the state economy. That's basically what it did. And then it laid out in there several ways to get there, and I'll talk about a few shortly. What has that resulted in? It has resulted in one of the highest healthcare coverage in the nation. I can tell you that despite all the challenges that I'm sure you have read about with our insurance website, we have actually increased the number of folks that have coverage today that they had 6 months back. So we continue to be on that path. I think we're fortunate to be in that place. And I think, as you might have recently read an article that came out with the first evidence where they actually associated better health outcomes from having universal coverage. And also, based on surveys, 91% of our residents have reported a mutual source of care. I will say that, if you look at the history in the United States of these type of initiatives, not every time they have been successful. And if you look at a differentiator between the times that it has been successful and not been successful, I think it ends up becoming about collaboration between the public and private sector. Every time that collaboration exists, the probability of success has gone up significantly. So I think we've enjoyed that across the board for quite a few of these. Having said that, there's still a ton more to do. We have one of the highest per capita healthcare expenses in the nation. Our healthcare spending has doubled in the last decade. And while we have launched ourselves into payment reform, only 30% of, so MassHealth, for those of you who may not know the term, is Massachusetts version of Medicaid. You know how every state has to have its own Medicaid program. They call it different things. We happen to call it MassHealth. So when you see MassHealth, it's basically Medicaid. You know, only 10% of our primary care practices are patient-centered medical homes. So a lot more to do. What's the vision? What's the approach? Chapter 224 essentially broke it up into 3 parameters. One is around system redesign. You all know about that. It's essentially the whole integrated model of health rendering healthcare, which is person-centered and is coordinated, requires high quality. Big, lofty words from a policy perspective, hard to implement, requires a very different paradigm to do, but that's part of it. Payment reform, again, goes with system redesign. You know, how we pay for our outcomes, how we pay for our performance, you know, bundle payments as against to fee for services. And then consumer engagement. You know, previous speaker talked about, you know, how most of us do not know the cost that is actually paid when we get medical care, and I think that's a key thing. And it's and wellness, the concept of wellness, right, which is really more about, you know, every time you show up to a doctor, you know, you get healthcare. Healthcare is a continuum which happens even outside of the you know, providers organizations. So the wellness concept and, you know, the community support programs, you know, that can go hand in hand, are seen in Massachusetts as a key driver to overall ultimately meet our policy objective, which is very simple: reduce the cost in the healthcare system and enhance the quality of the healthcare system. So that's the overall vision. So how does IT fit in? IT fits in a lot. IT is all over the place when it comes to this. In Massachusetts, I see, from my perspective, 3 very parallelly run key initiatives that are happening. One is this whole concept of integrated eligibility systems across means-based programs, which builds around the health insurance exchange but goes beyond that. The second biggest initiative, again, not unique to Massachusetts in any way or shape or form, is happening nationally, is the adoption of EHRs. You know, we are digitizing health records, you know, a great thing to do. However, it can only be beneficial if it can be transmitted across the boundaries. And that's where the HIE comes into place. And, you know, I was sitting in the back of the room, I was thinking that, you know, it's great that in 2014 we have sessions that have HIE in them. You know, if you remember, just a few years back that was not in our vocabulary. So I think it's good that, you know, we're beginning to talk about it. Clearly, we are not where we need to be. But I think it's great that these topics have become, you know, a topic of discussion, and we actually have slides enough to show about what they are as against just a concept. So as I said earlier, we are basically in Massachusetts building a middleman functionality. You know, you can call it a mass pie, you can call it whatever you want. It's a transport layer to get data from point A to point B in a secure manner as long as the patient is consented. I should also note that Massachusetts is an opt-in state. It's an opt-in state for physical as well as mental health. So unlike Maine or other states are, in New England, Massachusetts is an opt-in state. So consented information transmitted from point A to point B. That's the basic essence of the HiWay. Not everybody has to use it. If there are other ways of transmitting data from point A to point B within an ACO or amongst ACO, that's great. If folks want to continue to use you know, an existing HIE or a vendor provided HIE, that's great. But if you don't have a way and you need to have a way to move data around, you know, this solution is available. And we really see it as a hub. We see it as connecting more than just providers and payers and hospitals. You know, public health systems are on it. Behavioral health, lab, pharmacy, patients, small practices, the entire spectrum. Because, you know, that's really where healthcare happens. Healthcare doesn't really just only happens in hospitals. So this project started back in 2012. We too were recipients of ONC grants. One thing that we did differently in Massachusetts was we actually did not use the ONC grants to build the HiWay like many other states did. We were one of the first states, we actually were the first state to use Medicaid funding to build the HiWay. That's what was different about us. So what does that mean? What it means is that the federal government helps us pay 90% of the cost of building the HiWay, which you may say, well, using the grants, you could have gotten 100% to build the HiWay, so how is this a good deal? Well, it's a good deal because when you use Medicaid funding to build something, they also help you pay for ongoing sustenance of that. So they pay you 75% to the dollar for ongoing maintenance. So all of a sudden, if you think about the biggest challenges HIAs have had nationally, it's sustenance, right? How do they get to enough volume so that they can sustain themselves? That became simplified for us, significantly simplified for us, and I'll show you our price list, which was a direct result of us getting it funded through Medicaid. But in doing that, we knew we couldn't do it all in one go, so we focused on an initial phase, which was just focused on direct messaging, which was essentially doing what a fax machine can do, send data from point A to point B. And then in 2014, we had planned to launch the query and retrieve functionality. So this is the concept that I was talking about earlier. So imagine you have healthcare data that sits in different places, right? Like I said earlier, we made a decision not to create a longitudinal record in the center. We're not getting into that business. We just decided not to, for several reasons. What we did want to do, though, in the center was create an index or some kind of a locator which would tell us, given a certain patient, given a certain basic information that you can basically get off someone's driver's license, tells us where the data sits. And then an ability to request that data electronically and receive that data back electronically, not to the HIE, but to the providers that really need it at the endpoints. So for that, that's what this query and retrieve functionality means to us. You are querying where someone's health record is, and then you are retrieving that based on the results of the query. That's the basic concept. So on October 16, 2012, we had a Golden Spike event. Apparently when the railroads were being built in the US, somewhere in Utah, they met and there was a golden spike, so that was the general idea. We actually gave everybody a little spike which was painted golden, which someone claimed to have bought through eBay and that were used at the time of the original railroad construction, who knows. In any event, we did that. Governor Patrick was the first one to send his own personal record, health record, from MGH, which is in downtown Boston, to Bay State Health, which is in Western Massachusetts. So the first electronic health records that traversed over the highway to the governors. It was a great event. Since then, we have had over 100 organizations in Massachusetts that have joined the highway, and about 2.5 million transactions have traversed through it. And then on January 8th of this year, in 2014, we had the launch of the second service, which is the query and retrieve service. So in this case, at BIDLC, we demonstrated, we acted out a use case where a patient came in. The patient, was not communicating well, was complaining of pains in his abdomen and his head. And a typical, use case at that time would have been to run a battery of tests on the patient, find out what's going on, and what we demonstrated there was using an HIE. We were able to find out where the patient's health record sat, and we were able to pull them down, and essentially, instead of having spent 3 days and $30,000, we demonstrated how you could have had the patient, leave the premise in 30 minutes, with much less of an expense. Again, the CFOs may not like that, but that's kind of the idea of this. That's where the direction of this is, and that's the power of what we wanted to demonstrate. The governor was kind enough to attend that function as well, and so that concluded in effect, our building of the HIE, and where we are now is essentially in an operational phase to roll it out and get more and more folks connected to it. As I was saying earlier, these type of networks cannot work if they only rely on EHR systems to be able to talk to them. First of all, not every EHR system is in the same place. Second, not every provider will end up having an EHR system. The healthcare spectrum is comprised of a very broad-based, groups of folks, starting from, if you think about the user types, they're really very broad. So what we needed to do was come up with a model where, sure, if you had an EHR that can talk with meaningful use certified, that can talk in, using direct compliant messages, sure, you can use that to send and receive messages. That's great. In fact, that's where we want everybody to be. However, On the other end of the spectrum, if you don't have an EHR, neither you will ever have an EHR because you are one physician practice out in Western Mass, and that's just not really where you want to be, but you want to participate in the health information exchange. We do provide a browser-based, internet browser-based model where you can connect to the HIE and send and receive messages securely through that. And then there's the middle, which happens to be the broadest, which is, yes, I have an EHR, but it's kind of a legacy EHR, or the release that would actually do this is not available. What do I do? So we contracted with Orion. Orion is the provider of our state's HIE. They happen to have this great solution, which is kind of looks like literally like a little cable box, or a LAN box, local access network device. It sits within your network, and basically it can talk to your legacy EHR, current EHR, even your modern EHR. It essentially takes data from it in any format, in any standard, any transport format, transmits it over the direct protocol, over the HIE, in the same way on the receiving side. It can receive data in any format and transmit it back. So all of a sudden, this biggest sort of chucky, plummy issue of sort of transport in different formats became really simplified by this. In fact, I think 90% of our users in Massachusetts are using that LAN device. Not sure if you can read it. Suppose you can. It's a really big screen. The price point on this was fairly aggressive, and I think that was essentially because of the Medicaid funding. When we rolled out phase 1, the price ranged from $27,500 per year for a large hospital to use the HIE to as low as $60 a year, which is $5 a month. Basically, we didn't want to make it free, for a single physician practice group. And then the phase 2, which is a query and retrieve, the ability to go up, use someone's driver's license to go up and find out where the health records sit. That's available at an extra $15,000 a year cost for a hospital and $30 a year cost for a single practice. So there is some price structure. The price structure, I think, is meant in a way so that it ensures that there's a low price point for the tier 3s and 4 and 5 in order to essentially get them on board. And I think this has proved out on the field pretty well, where we have seen really a broad spectrum of users that have gotten on it. We're not just having the hospitals, we actually have gotten a lot of small practices that have gotten on the HIE. About 200 participants have already signed their papers in terms of their participant agreement to get on the HiWay. As I mentioned earlier, about 2.5 million transactions have traversed it. It's just a list of everybody that's on it. You can probably recognize some names on it. It's just the list continues of different organizations that are live on the HiWay today. So one of the interesting dynamics that we had to understand was, okay, great, so you got 70 hospitals out there, you got, 27,000 providers really at the end of the day, and, they're all using EHR systems, and, if they're meaningful use certified as part of meeting the criteria and as part of getting, the payment, as you all know, you have to demonstrate that you can send data, outside of your boundaries. However, what are the key players in Massachusetts? So we Massachusetts Electronic Health Insurer, MIHI, did a study about a year back of who are the primary EHR vendors that do business in Massachusetts. So as you can tell, and then what is their current status with HiWay? Obviously, my objective is to make sure that all of these, at least all of these vendors, which represent about 80% of the provider overall, can connect to the HiWay. And from a top vendors overall perspective, as you can see, Meditech, LMR is not a vendor, neither is WebOMR used at BIDMC. But those three are live on the HiWay today, and Cerner, Allscripts, eClinical Works, and GE-Centric are going through testing phases. Now, from an inpatient vendor's perspective, Siemens is going through a testing phase. Practice-based vendors, I think we are working with 4 out of the 5, and we are in discovery phase or testing phase with the long-term and behavioral healthcare vendors. Again, we will not say no to helping connect any vendor on the HiWay. but I think we wanted to keep an eye on the most used vendor in Massachusetts so that we make sure that we don't forget about them. Okay. I think we talked about this in the previous session that we are in this quantity-driven siloed space. We have this administrative claims side going through in Massachusetts that's going through Nehan. We have some clinical exchange, I guess, now that's happening to the HIE, and then this center silo of program-based quality is really something that we are all at different levels, but there's still a lot of work to be done. So one approach could be to just leave it that way, let it happen, let administrative transactions flow through a different channel than the clinical transactions, and then just the industry and market develop on its own. A sort of slightly different approach could be, which is what we are trying to do here in Massachusetts, is to start looking at the HIE as sort of as the way, as the hub for both quantity and quality data. It doesn't have to be just for clinical data, it could also be for administrative data. And then hang your, whatever claims management systems you have, or your different quality data repositories that you have, off the HiWay. And of course, to do that, you're going to have to make several enhancements. An eligibility system would have to be modified into an integrated eligibility system, and a ton of work needs to happen on the quality analytics side. So these are all of these oranges are different projects that are underway right now in Massachusetts in order to do this. But I think that's the vision that we are driving towards. And of course, you will always have some sort of shared services that support all these at different levels. So in terms of what's next for the HiWay, and then I'll pause and take questions. Again, the state's not getting in the business of developing a longitudinal state health record in Massachusetts. However, we are seeing and supporting these efforts at different places. There are already quite a few of these QDRs that are connected to the HiWay. Medicaid in Massachusetts is also building its own, so that's going on. And then the query and retrieve today is available through a web browser. But in order for this to be really part of the healthcare spectrum, we understand that it needs to be supported through web services. So imagine a place where a patient shows up in an emergency department, you put in the basic information, and the EHR, whichever EHR you use, can through web services find out where this person's external health records sit and pull them in. I think that's a vision that we can achieve. I think that is achievable, doable. It's a matter of time, and time is key here, because one of the things that we looked at nationally and even locally is how long does it take to roll something like this out, and the Nehan experience was about 6 years. It took about 6 years for this to become ubiquitous, and I think in the HIE side, Massachusetts, I think we are in year 2 or 3. So I think right now we are focused on increasing the number of folks that can get on it, and making the connection easier, as easy as possible. It is cloud hosted. It is hosted by a private vendor, and it's basically seen at the end of the day as a way to marry and merge clinical and quantity data and administrative data, so that we can get it in the hands of the ACOs, play into the needs of the ACOs, get it to a place where it can become meaningful, and help the whole sort of policy discussion or policy need that we have, which is about reducing costs in healthcare systems and enhancing quality. So that was my presentation. I'm happy to take questions, or we can talk offline as well. My contact information is up on the screen. Okay. Questions, comments? Yeah.
I could use the analogy of a HiWay being, you're just in the HiWay, you're in a phone book.
You're in what?
You're in a phone book, so you can be looked up into a phone book. And some of these other vendors may have their own HiWay, and they have their own phone book. So how do we get those two phone books to communicate? Who applies that pressure? Because you'd have one listing and then you have another listing. And it sounds like if you're in two different phone books, it's hard to actually get that cross communication.
That's an interesting question. So I think here's what I think is going on. I think EHR vendors in general are graduating into the, or some of them at least, are wanting to be in the HISP space. They want to be health information service providers. As part of being a HISP, you do exactly what you're saying, which is phone book or provider listing or some provider directory. Different people call it different things. The fact is, there's no national standards around that today. Yes, there are some movements like Direct that are trying to do that, but there really doesn't exist. So what we are doing in Massachusetts is we're trying an approach where we're using a PKI-based solution for pure authentication, but from an authorization perspective, we are creating something called a whitelist, which is essentially a central repository of the phone book that you referred to. And it pulls the phone books from the HISPs that are participating with us, so that we can, our HiWay participants don't have to go to multiple phone books. They can get that data in one provider directory list. That's the concept that we are trying. I think nationally, I think that is one of the areas that is lagging behind in terms of standards. I think we can use some better standards on that. So that's kind of, that's a good question. It's one of the key challenges. Okay. All right. Well. Oh, okay.
I always have a question.
That's okay.
I'm curious about the money that the EMR vendors can earn doing the integration services versus what could happen on the HIE. Is there some impact there? And is that an issue for some of them?
Well, whether something is an issue or not depends on where you stand. It's an interesting question. I think EHR vendors in general, I think so nationally we are about 75% EHR, if there's a word like that. Massachusetts has a higher level of EHR adoption. That's a dying market eventually. So if I'm thinking from as an EHR CL, I'm thinking, okay, where's the next growth coming from? And I think the growth is coming in interoperability. So, do I start a model where I charge a transaction fee for every time, text messages, are transmitted? Do I charge a one-time fee to set up an infrastructure that can do it? And I think you will find, what I'm finding is about 8 or 9 key EHR vendors are on the former, in which they want to create their own HISP. And then, fortunately, some of the bigger ones are not. Meditech, for example, which happens to be one of the, it happens to be one of the biggest sort of coverage vendor in Massachusetts, at least, has decided to use just pure XDR to connect to the HIE. They're not looking into charging transaction fees, and we clap on that. So I think it is a bit of an issue, I think, from an EHR perspective. From our perspective, from the state's perspective, from a policy perspective, we try to reduce cost. So we don't want to have this as just another way of, another way to add to the healthcare cost. We want to use this to avoid labs, avoid EDs, avoid tests, avoid rescans, reduce the stay. So our policy objectives are that. I think unless and until, and I think that train's left the station, but unless and until the system reform, the vision slide that I showed earlier, those other pieces, the system reform and the payment reforms, don't fully take hold, and hospitals and payers are actually participating in the benefits of the cost savings, I think that's when there will be this sort of environment effect of using technology like HIE to actually, render it. I think right now, for some, it's a nice to have. For some, it's only they're using it maybe, in order to get the meaningful use to payment. Those are not sustainable reasons for why, an HIE then will stick. I think the HIE will stick when the payment reform gets full. And I think that's when the CFOs will also get on board, because they'll say, well, gee, I'm going to get the same amount of payment no matter what. If I can I can pull data, and I can get that data beyond it, can avoid me, unit cost, and that's better. So I think that's really where it is. How long that journey will take, I don't know. 6 years, 5 years, 10 years, I don't know. I hope to be around when it happens, but I don't know how long it takes. But that's the policy push. I think that's what we are trying to do. Yes?
I'm sorry if I don't phrase this well, but
That's
how
okay.
would you see the predictability working?
As I understood you to say, the patient's data stays within the particular
Right.
organization. So how would you be able to predict 70% readmits for an ACO, for example?
Right, so that is a great question that has to be answered. The HIE will not answer that question. We are not in the business of answering that question. The model here is that we are in the HIE is the head of HIE is, to get data from point A to point B, know where data sits. But then we are relying on the market, on this group, on folks to develop solutions like the QBR, like the thing we saw that Maine is doing, which would then collect that data and do that type of analysis. Whether that's done in the context of an ACO, a couple of ACOs, the entire state, the entire nation, all the power, go do it. This is about solving a very basic infrastructure issue that we have today, that we can't get data from point A to point B in a standard format. That's what this is about. In some ways, I think it's about managing scope. It's about what do we want to do and how do we want to do that. We do want to expose this to patients. We will expose this data to patients in that, as a patient, I should be able to know what does the HI know about me as to where my data sits, but not directly to the point that you're making. That's not in scope, if you may, from this project perspective. Yes.
Can you update us on what's going on in the patient opt-in and how that's going across the state, getting patients to sign in with status?
It's going great. We are an opt-in state. We respect that. I think that's who we are. And if you talk to the hospitals, and at least the ones I have talked to, or what my experience has been, that people are okay with that. The rate of success is very, very high in terms of people that sign that consent. If it's used for healthcare purposes, for the right things, I think, I think we do it. I think, it's kind of funny, right? Because as a society, we often talk about our health grievances to each other very openly. My knees hurting me, head's hurting me. We rarely talk about our finances in the same way, right? We never say, well, I've got so much money in my bank. Yet, we are happy to put our finances on the, on a portal, and we are sort of like, I don't know if I want to put my healthcare on the portal. So, from a consumer perspective, from my own perspective, what we are seeing, I think people are okay. It's not been a hurdle. It's not at a point where we have to say, go back and request the legislature for a change. It's not come up. And Maine has a different model. I think Maine, I don't know, Maine folks are here, but the opt-in is only for behavioral health, from what I understand in Maine. Yeah. Yes?
The query and retrieve, is the response automated?
So let's break that up into two parts.
Okay.
The query, so how does it work, right? So let's say I show up in an emergency department, I can't speak. They'll take my driver's license, and they'll go to the HiWay portal right now. They'll enter Manu, Tandon, date of birth, address, and in real time, it will come back and tell me, I have a record at Beth Israel, at MGH, at Bay State, and what have you. Okay, so that's part A, that's in real time. Now part B, which is, get the data from MGH and BIDMC and Bay State. Now that depends on the capabilities of MGH and BIDMC and Bay State. If they are an EHR shop that can respond in real time, it will come back in real time, the request will be responded. However, if it's a shop that doesn't have an EHR, then maybe they will just receive the request and then fax the information back. It depends on the sender and the receiver's capabilities for that.
Is the real time, is that XDR based, or is that?
Yes, it's both XDR and SMTP based. So this whole thing is based on direct, capital D direct protocol, yes.
Thanks.
Yeah. Yeah.
So if I'm an organization and I want to worry about network leakage.
You want to worry about what?
Network leakage.
Network
And
leakage.
I have, I know all of the patients that are going to me and my specialist because I have that relationship. I'm all set. But I'm worried about the patients who are going outside my network who I am not aware of. Is there any way in your system to say, if Mary goes to see the cardiologist in a different system, rather than doing the query, the query is a solution to this, but in lieu of that query, and saying, I want to subscribe to all of Mary's messages, as long as that physician says, yeah, no problem, I know who you are, you're Mary's PCP, I'm Mary's cardiologist, we're all cool, I authorize. And Mary says, yeah, I'm all authorized, however that's working. Do you have any capability of doing a subscribe model? Because the HIE world has been talking about this for years, and most people have never succeeded in doing it.
So the answer is yes. If Mary consents to it, that's the key part. If Mary consents to it, number one. Number two, if you are an active contributor to the HIE, in other words, if you've been sending us ADTs about your patients, and if the other provider organizations are also in the business of sending us ADTs, and Mary ends up there, you want a notification and an alert that your patient was seen somewhere else, or a primary care physician wants to get an alert that their patient was had an ED visit. What we have put in phase 2 in January of this year, that exists. However, in order for this to become real, what do we have to do is we got to populate that relationship listing service with all the ADTs. So Chapter 224, the law, Massachusetts says that by 2017, everybody has to participate on the HIE. That's how it says right now. In the process of defining regulations as to what that means. But imagine a world where we can get, like Maryland has done that, where we get those ADTs in, now that we have the infrastructure in place. We're actually now working with at least 4 major organizations to populate the ADTs, and starting mid-June, we will begin to populate it with ADTs. If that ADT exists, the technology exists in order to do exactly what you do. In fact, that's what we want to do. That is what the policy goal here is, to get that in. Thank you for that question. Okay, if no more questions, we'll be the next speaker.
Great, we're a little ahead of schedule, and probably people might be ready for a stretch. So we'll take a brief 10-minute break, let's say, and then start up with Scott Margolis at that point, which let's say right at 10:30. I'm sorry, 2:30. 2:30. Yes, it's been a long day. And also one more reminder to, so this will be our last break, so please visit the exhibit tables, and last chance to enter the raffle drawings. And just one more comment. I think it was actually great to have Maine Health InfoNet and Mass HiWay back to back. We saw 2 different but complementary models, and I think we should all feel that we're in excellent hands with both brilliant strategists and excellent implementers. So please join me in thanking again our last 2 presenters.